done is basically trying to get everybody who is associated with perinatal mental health involved. So not keeping it in the domain of psychiatry alone, but having colleagues who are psychologists, who are social workers, who are nurses, obstetricians, public health people in policy to get, and as well as users, consumers, and their family members to get involved. So I think perinatal mental health is something which is a unifying force in many ways, and the credit for all the work that is being done in South Asia goes to a whole lot of people. In every country in South Asia, there are people who are actively involved in the field of perinatal mental health, and some of them, such as Professor Atif Rahman, very well known across the world. So I think that we are at a position where South Asia needs to be somewhere on top in the context of perinatal mental health. And so I thought I would address some of those issues and not take away from what is going to be discussed in the panel discussion, but highlight some aspects of why we need to give voice to this silent burden in South Asia, and why perinatal mental health, and how and why now. So I'd like to answer it by addressing 4 questions. How is the South Asian situation unique? In what way are the countries that we are from are unifying factors? So many things that are very special to this region. In what way are we unique, and why do we need to address? What do we already know? I mean, if you scan the literature from South Asia on perinatal mental health, it is quite enormous. There are so many people who have done so many studies. Many of them are in the panel today, and some of them may be in the audience as well. But I think we know quite a lot already in terms of the extent of the problem, the prevalence, the risk factors, outcomes, and I think a fair degree of research has happened. But there are certain things we still do not know. So we're going to talk a little bit about what are the key questions for us, and then leave you with this whole thought about how can we make a difference. I want to emphasize here that, the South Asian voice, like Dr. Ashlesha has mentioned, has been kind of absent in the Maasai society. I would say nearly absent. The reason is any conference that we go to, there would be about 5 or 6 people from any country in South Asia. And several of them who do represent us are people who live in the UK or who live in Europe or America. So we really do not have people coming in from South Asia and talking about what's going on in the field. I think there are reasons for this. One is resources. Many of us may not have the resource to travel to a high-income country, stay there. There are issues of visas, and we know that even within the South Asian context, we face all those challenges. So I think it's about trying to figure out how we are going to overcome those. So I'm going to start with this world map on birth rates, and I think this is to me, it's very important. This website, many of you know, is called the World Mapper, which basically looks at the world using different data points. So it doesn't look at only geographical area, but looks at various kinds of data points. And if you look at this world map as a birth rate data point, you can see that the maximum number of births are happening in our region compared to all other areas of the world. And if you see the most frugal ones, the purple and the blue American, and some of the other Australian yellow ones, that's where the birth rates are not happening as much as in South Asia. But ironically, all the services in the world are actually concentrated in these places where the birth rates are really low. So all the innovations, all the new things that are happening and coming to us from countries which have higher resources and which have lower birth rates. Which basically means that if we try to adapt what is going on there, we are not going to be really very successful. So we need our own language, we need our own newer methods of addressing, both at a clinical level as well as in the community, because we definitely are unique. And one of the uniqueness is shown by this map, that the extent of the problem So, and of course, I don't have a map of, let's say, mental health professionals or professionals working in perinatal mental health. But my sense is that it will be just the opposite, that India, South Asia will be kind of narrow and all the other parts of the world will be much larger. So we have different pools of health professionals. Many of our countries may not have doctors, but we have other kinds of professionals available. So I think we really need to be thinking extremely uniquely and innovatively about this problem. If you look at some of us who are working in clinical situations, as psychiatrists, as psychologists, and other perinatal mental health professionals, also lament the fact that we don't have enough inpatient services dedicated for women who have perinatal mental health problems. And this is really sad, because if you look at the UK, for example, with a lot of advocacy, there was a point, I think, in the 2000s, and I trained in what there were, I think, some 7 mother baby units across the UK. And now there are probably 40 or 45 units across the UK, and almost every county has a mother baby unit in some form or the other, like daycare or some form or the other. So I think it's important for us to again address this issue. There's been a great reluctance and hesitation in our countries to actually start mother baby units. Sri Lanka has a mother baby unit, which is run really well, and it's a very well designed unit. But then these are the only 2 services which are available for women with slightly more severe mental health problems, who need, or with personality disorders, or who need sort of prolonged kind of specialist care. So I think we need to also think of various levels of care that women need. Where are we going to put our money in? What are we going to prioritize? I heard Patrick McGorry talking the day before yesterday, and he said, even though we talk about, let's say, India or Bangladesh or Pakistan, or any of these countries as low-income countries, within these countries, there are pockets where there are high resources, there are low resources and middle resources. So the countries are not the same. The country is not the same throughout. And that's true for India, and my sense is it's true for other countries in South Asia as well. So we really need to see how do we plan services which are going to be able to cater to a large section of women, both those who have common mental disorders in the community, as well as those who need specialist care, maybe specialist outpatient care, and those who need more specialist inpatient and intensive care. So I think these are things that we should be starting to think about at this point. Well, this is not new to us. And this is the gender inequality map. I didn't get the gender inequality in the world mapper, but my sense is that if we had it in the world mapper, you would again find a very similar profile. Gender inequality is by the index done by the World Bank is assessed on various parameters, as we know, and the dark red ones are where the maximum inequity happens. And you can see that again, our countries have the maximum inequity. Why is this important? It is important because help seeking depends on equity. Women's well-being depends on equity. And we know that some of the strongest predictors of perinatal mental health problems are gender-based violence, as well as poor support systems. We also have some unique cultural issues in our countries, at least most of our countries, and the concept of patriarchality, which is, a young woman moves from her maternal home to the home of the husband or the spouse, which again, and becomes pregnant very fast, usually unplanned pregnancies very early on in life, which again, make her extremely vulnerable to some of these situations. Patriarchality, for example, is a unique South Asian concept which has absolutely not been addressed either in relation to women's mental health or in relation to perinatal mental health. So these are some extremely unique situations. Gender preference, for example, the preference for a male child and the pressure that it puts on a woman. Now, these are things that, Western studies will not talk about, they will not address, and it's something that we will need to develop. Professor Vikram Patel has shown the importance of the relevance of male infant preference on perinatal mental health and violence on perinatal mental health. We've had studies from the Pakistan group from Dr. Atif Rahman, Dr. Seham's group, where a range of such risk factors have been shown. But then how do you address some of these? While we've been focusing a lot on the woman in many of the programs, the emphasis on the partner and the family has probably not been enough because of cultural issues. So how do we all learn from each other and try and address some of these issues which make women more vulnerable to have perinatal mental problems? A third issue which I want to discuss is about suicide. We know that maximum rates of suicide in South Asian countries, except for Sri Lanka, all other countries, the rates are highest among women between the ages of 15 and 29 years, which is basically the reproductive age group in these countries. And if you look at the male-female ratio of age standardized suicide rates, this is 2012, but the latest data is no different. And if you look at the WHO reports of 2014, the latest report has also come out. If you look at the female-male ratio, the whole gender paradox has shifted. And this is specifically among women between the ages of 15 and 29. So you have India, Pakistan, Nepal, Bangladesh, except for Sri Lanka, like I said, all countries where rates in this age group, specifically in certain pockets, the rates of suicides are higher among women. This is something which needs to concern us, because we know that maternal suicide can have devastating effects on the child, on the family, and I think it's something that we really need to think of, because these are all probably young mothers who are dying. Some of the data from our center, where we are doing a longitudinal study of 900 mothers in the community, have again shown that the rates of suicide are the highest within the first year of childbirth. And the kinds of suicide attempts seem to be also much more lethal than non-perinatal period. So this is something that only we will be able to address. Other countries are really not interested in this phenomena, because for them, suicide in women, even though maternal suicide is a big issue even in many countries, but for us, and in those countries, an important aspect which is different, again, unique, is that in most Western countries where there are confidential inquiries and maternal deaths are being assessed, the reasons for maternal deaths are untreated psychiatric illness. Whereas in our countries, it's a whole lot of psychosocial risk factors which make the woman vulnerable to develop maybe depression, maybe suicide. So I think these are some things which we need to see. Again, if you look at the whole world, these are the top countries where females and male suicides, if you can look at the rates, again, something which should concern us, because it is between the ages of 15 and 29. India has been desperately trying to develop a national suicide prevention policy, and we are still not successful, even though so many of us are talking about it, especially for women in the most vulnerable age group. Another area which I think is, again, important for South Asia is to try and develop confidential inquiries and confidential review of maternal deaths. In India, the only state which is doing it is Kerala. And I know Sri Lanka has done the confidential inquiries, but in no other country we have confidential inquiries available. And I know we have an obstetrician in our panelist, who will be able to advocate for this, because it's usually the public health and the obstetric groups who do the confidential inquiries. But Kerala has included a psychiatrist in their team for confidential inquiries. And in this study, in the recent 2010 to 2020 study from Kerala, suicides were one of the, I think it was the fourth or the fifth reason for maternal deaths. So again, I think something that we all need to address, because even Sri Lanka has identified, and Aruni will talk about it, the need for emphasis on suicide. So my second question was, what do we already know? So all this is unique. Studies which have been had publications in various articles about prevalence, about determinants, about perceptions and attitudes around perinatal mental health, about the role of poverty, food insecurity. So I don't think that we need to do yet another study on prevalence or yet another study on risk factors. Maybe we need to look at something so more unique situations, more cultural factors, and try to address those. But we know enough about the prevalence and rates of any of these, and we know that despite all the support that our women get, all the joint family system and community support, regardless of that, the rates of mental health problems seem to be pretty similar. In fact, probably more in certain more vulnerable populations. I don't think there's been very good quality studies looking at trauma and women who go through trauma. I know there are studies from conflict regions in Pakistan and Sri Lanka, but trauma as a concept of growing up, we don't have enough data on that. And how do we provide trauma-informed care for women who come to obstetric settings? Obstetric violence is another understudied area in many of our countries, which again is something which contributes to poor mental health, especially among women who have pre-existing vulnerabilities. COVID, I think, has so why now? Because I think COVID has highlighted, of course, all mental health problems, but particularly the great difficulties which women in the perinatal period struggled with during this period. And we have data from all countries, from Nepal, Sri Lanka, Bangladesh, India, about, and this is when we start doing a search, the amount of research coming out, even though our resources may not be enormous, is really impressive. The fact that we've been able to do so much. But I think in terms of the interventions and advocacy and action points is something that we really need to be focusing on. So in terms of interventions, I think that the best interventions that have been studied include the Thinking Healthy program, both in India and in Pakistan. I always tell policymakers when I meet them that the WHO has adopted the Thinking Healthy. It is, the data and evidence is available. Yet, in terms of policy, things haven't changed. So in India, we still do not have, so although in name, with a lot of working with the government, perinatal mental health needs to be integrated into maternal mental health. There needs to be intervention. There is, I think, only Kerala has started the integrating maternal mental health into routine programs, and that too because there are psychiatrists there who have a lot of interest in this area. So it's become very person-driven rather than policy-driven, and maybe that is where the consumer movement needs to come up, because recently we had a great consumer movement in the state of Karnataka, where we used the change.org and Ashlesha, myself, with some very young people and users, started a movement, and we were successful in the latest mother baby card to be able to include 2 questions on mental health and 1 on the past history of a mental health problem. And that has taken us nearly 5 years of sort of constantly discussing with policymakers. But hopefully we'll get some data, because all of this goes into a data bank. So I think though there's so much evidence, both of community-related interventions, a mother-baby unit at NIMHANS in Bangalore, which has shown that outcomes are good. Despite that, in terms of actual practice and action and policy, not much has happened. So I think that it's really important. And but it's marvelous to think that all of us with limited resources have been able to do so much. I mean, I think that itself is a great credit to the South Asian spirit, and we really need to make sure that we continue that with together. I want to end on the note that I think one area which we really need to focus on in our countries is on gender transformative interventions. So interventions can be gender sensitive, they can be gender intentional, they can also be gender transformative. And to me, perinatal mental health, especially the kind of risk factors which we see both clinically and in studies, require gender transformation. And I think much of our work will, and this is again a uniquely South Asian situation where gender inequity being so high, violence being high, the degree of involvement of partners, husbands, both in family planning as well as support and household chores, etc., seems to be really lacking. So there is a need to sort of, enhance this, and there are we've just finished a review on gender transformative interventions in perinatal mental health, and we've found very, very few studies, not just in South Asia, but the world over. There are studies on maternal health, which have maybe one component of depression, but there are no studies, or very, very few studies, which have actually looked at gender transformative interventions. And this is going to be a challenge in our countries, because with such strict gender norms, how do you, even break this barrier? How do you address men to get a bit more involved in all these situations? So I think that is something we really have to focus on and learn from each other. So the African Alliance has already beaten us to it. They haven't started an African South Marseille Society, but they've started an African Alliance for Maternal Mental Health. They recently had their big meeting, and have started charting out their own agenda. So they have a byline, which is educate, advocate, and act. So we will also need to think of our own byline. So what are the key questions for us? I sort of highlighted. I think the panel will take on more. How can we make a difference? Again, I'm hoping the panel will come to some, and we are recording this, so hopefully we'll get more ideas as we listen. So to me, the South Asian Marseille Society should be to educate, to advocate, to act, to understand, and to transform. And I think transform is something that I would like to highlight, because there is a lot of things that we need to transform in the minds of mental health professionals who do not consider perinatal mental health as a separate specialty section, or they just don't think that this is something which needs attention, and transform in so many other ways that I mentioned. And hopefully in terms of outcomes and in terms of, let's say, suicide rates, we hope that if we continue to work together and do something, it might actually make a difference. So I'm going to stop here, Ashlesha, having raised a few major points, and I'm really looking forward to the panel to see how we go ahead with the South Asian Master. Thank you so much.
Thank you so much, Dr. Prabha. That was really enlightening and a great start to our morning. I'm looking forward to the panel discussion as well. And without further ado, I will actually hand over to Purnima Mahindru, who is a perinatal psychologist with us at Green Oak Initiative. And she will introduce the panelists and the moderator. Over to you, Purnima.
So good morning. So thank you for being here, and it's quite exciting to see the launch of South Asian chapter of Marseille Society. So we will be initiating this with a panel discussion about maternal mental health in South Asia, and our moderator for today is Dr. Geeta Desai. So she is a professor of psychiatry in MHANS, has specific research specialization in chronic pain, illness behavior, somatoform disorders, and perinatal psychiatry. She has been a great researcher. She has almost more than 50 publications in national and international journals, and is actively involved in various national research projects. We have with us one of the panelists, Dr. Krish Srinivas. He's a professor of OBG in Bangalore Medical College, and has been a gold medalist and has published various papers, and has a lot of achievements and applauds in his kitty. Next panelist is Dr. Saroj Ojha from Nepal. So he's a professor and head of Department of Psychiatry at Tribhuvan University Teaching Hospital. And he has also almost more than 45 articles in peer-reviewed journals, has been principal investigator of national mental health, has been a co-author in mental health system in Nepal, and has published a couple of chapters in postgraduate psychiatry, and is has been supervising more than almost 25 postgraduate psychiatry students, MPhil clinical psychology students, and also is a commissioner for the Nepal NCTI approved commission, and is also a great researcher and is involved in various international research collaborations. Another one, we have Dr. Hilal Uddin Ahmed from Bangladesh. He is an associate professor of child, adolescent, and family psychiatry at National Institute of Mental Health. Along with that, he is also joint secretary in Bangladesh Association of Psychiatrists, president-elect Bangladesh Association of Child and Adolescent Mental Health, member secretary of Technical Task Team Bangladesh, and also involved in National Mental Health Strategic Plan Working Group. Next, we have Dr. G. Ragesh. He is working as a lecturer of psychiatric social work and is a registered psychiatric social worker at the Institute of Mental Health and Neurosciences, Calicut. He has done his MPhil and PhD from NEMHANS and has worked as a junior consultant there and has been working in the field of perinatal mental health since almost past 8 years. We have with us Dr. Siham Sinkandar from Pakistan. He is a professor of psychiatry and global mental health at the Global Institute of Human Development at Shifa Tamir-e-Millat University. He's also a global mental health academic with interest in developing and evaluating task-shifted health system-based maternal mental health and childhood developmental interventions in low-resource settings. He also holds a joint position of senior clinical lecturer at Department of Primary Care and Mental Health at University of Liverpool. Another panelist we have with us is Dr. Aruni Hangappa, who is joining us from Sri Lanka. She is a senior lecturer and head of Department of Psychiatry in Faculty of Medicine, University of Kerala, Sri Lanka, and is also an honorary consultant psychiatrist in North Columbia Teaching Hospital. She has been awarded the Andrew Sims Gold Medal, and she has also done her. Sorry, something happened. She has also worked in Royal Melbourne Hospital in Australia and has done her training in consultant licensed psychiatry. She has also obtained her fellowship in the Royal Australian and New Zealand College of Psychiatrists. She has special interest in perinatal psychiatry and has co-authored several papers on detection and treatment as well, and has a keen interest to develop perinatal services in Sri Lanka. She has contributed to develop a screening tool to assess antenatal and postnatal psychiatric disorders among Sri Lankan women. She has more than 40 publications in peer-reviewed journals and more than 50 conference presentations, and has won presidential, vice chancellors, and Senate awards for research, and also has co-authored a couple of books. Presently, she's a co-editor of the Sri Lankan Journal of Psychiatry. So I welcome all the panelists, and I'll hand over to Dr. Geeta to initiate the panel discussion. Thank you.
Thanks, Purnima, for the introduction, and a warm welcome to all the panelists. And a very good morning to all the participants who are listening to this, participating in this webinar. So during this hour of panel discussion, what I'm going to do is, since we have representations from various countries, so I would ask some specific questions related to the country, as well as some generic questions as well. So let's begin. The first question is to Dr. Hilal in terms of, can we just start understanding? I know that Dr. Prabha mentioned about the burden of mental disorders in Indian setting. So can we begin understanding, what do you think? I mean, what is your assessment of burden of mental disorders in Bangladesh? And if you can discuss that, and then what are the services that are available currently exclusively for maternal promoting or treatment of maternal mental disorders?
Thank you. Thank you, Professor Geeta. And at first, give my gratitude to the Prova regarding these very nice presentations. And again, I provide my thanks to all of the participants and panelists to include me in these sessions. From Bangladesh, I want to introduce the Bangladesh Mental Health Service first. Actually, the Bangladesh is a country in the Southeast Asian country, and we have only 300 plus psychiatrists And the psychologist number is very low also. Total 500 psychologists are working here, and some of their clinical psychologists, some of the counseling psychologists, some of the school psychologists. That means that in the service, the number of psychologists is very poor, and also the number of psychiatrists also very poor. That is only 300 for 160 million people. And most of the psychiatrists are gathered in the main city, that is the centrally, the tertiary care hospital, the medical colleges, the National Institute, and others. And in 2018, we have done our National Mental Health Survey. It was the second National Mental Health Survey from Bangladesh. And 2018, we found among the adult population, we have the 18% mental health condition among the adult, and 13% mental health condition among the children. That means the adult population is more mental health disorder in Bangladesh in the 2018 last mental health survey. And we found there is a very huge treatment gap. Actually, the treatment gap is huge. Among the adult, the treatment gap is 92%. And among the children, the treatment gap was found 94%. That means out of 100, only 6 children can access to the treatment. They can taking the treatment of any mental health condition. And regarding the adult mental health, we found that depression is the highest. It is 6.7%, and it is almost 8.8% in the female population. Total whole population, male, female, it is 6.7%. But in case of female, it is 8.8% in Bangladesh, we found in the National Mental Health Survey. And our service, that is the provided the mental health service only confined in the tertiary care hospital, the national institutes, the medical colleges. But we have our 3 layers of healthcare system: primary healthcare system, secondary healthcare system, and tertiary healthcare system. Primary healthcare system is confined in the sub-district and villages, and the secondary healthcare system is like the district, and the tertiary is the medical college and specialized hospital. Unfortunately, there is no provision of formal mental health care in the primary and secondary healthcare system in Bangladesh. We can provide the mental health service only to the tertiary healthcare. And Bangladesh have 2 specialized hospitals for mental health. One is National Institute of Mental Health. It is now 400 bed, where I am working here since 2006. And another is the Pabna Mental Hospital, that is solely the service hospital. It is 500 hospital. That is not a academic hospital. That is solely service hospital that's situated in the outside of the Dhaka in another district. And regarding the service in the primary healthcare, we are trying to integration of the mental health service through several government projects and public-private partnership. Recently, we have developed a new project, that is the SIMH, Special Initiative for Mental Health. Nepal also with us in the WHO SIMH project. And this project, we are trying to provide mental health care to the primary health care through the trained human resources. Because we will not able to develop our mental health experts, psychiatrists, and psychologists overnight. So we have planned to train our existing healthcare providers, the doctors, the nurses, into the mental health. And we are using the tools, that the intervention tools, that the image gap tools. You all know about the image gap tools, mental health gap action program. And Bangladesh already contextualize and customize the image gap intervention guide for their own. And that has a very good portion for the maternal mental health and women's mental health there for their intervention. And we are trying to training the primary care level doctors, nurses, and others. And in spite of this, I like to say my few words regarding the policy and the program of Bangladesh. Bangladesh has stand-alone mental health policy that is under process for finalization in the Ministry of Health. Stand-alone mental health policy we have, and in the mental health policy, maternal mental health prioritized and addressed very well. And we have our mental health strategic plan. I am working as a member secretary of that strategic plan working group, And this strategic plan is aligned with the SDG and WHO action plan. And this strategic plan also 4 objectives, and one objective is the integration of the mental health care in the primary health care, and also it has also addressed the child, adolescent, and women's mental health especially. This is our policy level and program level. Now I come into the maternal mental health service in Bangladesh. Actually, I am working in the institute, National Institute of Mental Health. There is a separate department. This department, I am one of the unit chief of one department. That name of that department is Child, Adolescent, and Family Psychiatry. That means this department is not deal only with the child and adolescent. Like the other, we have the other department in our university, Bangabandhu Sheikh Mujib Medical University Psychiatry Department. That is the child and adolescent psychiatry, But in our institute, we include the term family. That is the child, adolescent, family psychiatry that can emphasize the maternal mental health. And the maternal mental health service is depends on the total. Actually, we have no other specialized psychiatrist or specialized mental health expert for maternal mental health. We all the psychiatrists, general psychiatrists and child psychiatrists, we are all providing the maternal mental health service. We have very few studies in Bangladesh, and we found the maternal depression, especially the antenatal depression, found 18%. Rather, the general population, the depression is the female is only 8%. That is with a more than double. And in another study, we found the postpartum depression is 28%. That means it is also very high in rather condition. Recently, we have did a small review. I just complete my sessions. That is the recently we have done an maternal mental health depression policy paper with the organization of the Society of the Gynecologists in Bangladesh, OGSB, and the Bangladesh Association of Psychiatrists. And the action needed to address maternal depression in Bangladesh. The key components we found the gather additional evidence, because we have very low number of evidence regarding the maternal mental health, perinatal mental health. And we strengthen our national policy to develop our maternal mental health and develop a standard diagnostic tool and screen all women. Recently, we are using the Edinburgh postpartum scale that is already validated in Bangla. And we also use the PHQ-9 and WHO well-being in many various aspects, and enhance the provider capacity to provide the service through the primary healthcare, not providing by the psychiatrist or mental health expert. And we need to raise the community awareness, because previously I said our treatment gap is so high. So first we have to decrease our treatment gap. And last, I want to say the Bangladesh is emerging in our mental health service. And those people who are taking mental health service, they are taking the mental health service from the mainstream healthcare providers. They are taking mental health service from the psychiatrists, psychologists, or the doctors. They are not going to the indigenous healer 20 years before like that. So we are changing. There is a paradigm shift in Bangladesh. People are need the scientific treatment. And I hope with this collaboration and this webinar will help us a lot, and we can work together. Thank you, and thank you again for giving me the opportunity to say a few words. Thank you.
Dr. Geeta, you're on mute.
Thanks, Dr. Helal. I think you've two important points I gather is one is this inequitable distribution of healthcare professionals, especially the specialists in the urban centers, and very poor distribution in the rural centers. The second thing is also about lack of specialist providers in perinatal mental health. I think that's another point that you've highlighted. But I'm very happy to see that there are a lot of initiatives that have been thought out to improve maternal mental health care. But I also see that you're making efforts in terms of overall integrating general mental health care into the primary and as well as at various levels of health systems. So now moving on to Dr. Ragesh. I think, now we know that there are mental health problems. There are services available which are not probably equally distributed. What do you think are the barriers for women, to seek help or treatment?
Yeah, thank you, ma'am. And first of all, I thank the organizers for giving a chance to be as a panelist in this program. Regarding the barriers considered in the Indian context, we can classify it as mainly as four barriers. One is related to the healthcare system that is available in the country, and another one is the community issues or cultural issues, and familial and individual aspects. If we consider the health system per se, we know that the budget provided for this healthcare system, it's very low from the government. Also in India, though it is a there is a union health ministry, but the healthcare provision and healthcare services are divided in the states. States are handling the health subject. So the disparity is there, huge disparity between the healthcare services provided in each state from state to state. That's a main issue that is a challenge in considering our country. And another thing is that our healthcare providers, pan India, it is not adequately trained in maternal mental health care, and even not oriented. I can say that not oriented adequately about including our obstetricians, pediatricians, gynecologists, psychiatrists, and other mental health professionals. And also, we can say that inadequate specialist treatment facility. We hardly have one mother-baby unit in our NIMHANS, nowhere in our other parts of the country. And also, we can understand that the inadequate importance is given for the cultural psychosocial factors. So mainly depend on the pharmacological aspects for treating, identifying all those things. So we need to give much more importance to the cultural, social, psychosocial factors in the treatment and the rehabilitation in all other aspects. So if I say about the community aspects, you know that it is too much regarding this stigma and discrimination and misconceptions regarding mental illness in general in our country, or even we consider as a South Asia and even other parts of the world, we can see the stigma and misconception regarding mental illness. And actually, in my experience in some parts of the country, this perinatal mental illness not even considered as a mental illness. It is considered like a magico-religious attack or magico-religious aspects, or there is a magico-religious explanation for having this mental illness and not treated, not taken to the treatment centers and not given treatment or not completed treatment. So these are the community aspects that we can see. And also all these are related to actually poor support to the patient or to the mother and children in general. And yes, we already spoke, Prabha ma'am already spoke about the gender inequality and prevail in the community. That itself a great challenge in providing or seeking treatment and to act as a barrier. With regard to the family, the same thing. The gender violence or domestic violence is too much in considering our other parts of the world, and also related to lack of support from family of origin and even family of procreation. Also, the support perceived by the mother is very less. And also, yes, poor knowledge about the illness and how to take, when to take for the treatment. All these things are very difficult. And if we consider the pathways of care, almost all the mothers are taken to some kind of magical healer before taking to a scientific medical treatment. That's a major challenge in providing treatment. Also, when we consider individual factors, we can see that almost all the women are not adequately empowered, because we need to consider the women empowerment, literacy level, and the support that she receives, perceived, and even thinking about her ability to take decision or her own healthcare. All these are very challenge for women to seek for support. Even she understands that there is a need to consult or take this treatment. It is very difficult for the mother to go for a treatment. These are the these are the major aspects for as considered as a barrier in seeking treatment in our country.
So, thanks, Ragesh. I mean, I think you've made very important points, in terms of what are the barriers at various levels of system that, impede seeking treatment. And I think one of the things that you've talked about, the emphasis on social factors that influence maternal mental health. I think that is something that is, because we are always discussing in terms of illness models. And I think, you've really highlighted some very, very important aspects. So now, one is, we were discussing about services, maternal mental health services. So would you like to highlight in terms of in India, how are the services that, provided? What kind of, like you mentioned, rightly said that each state has different ways of doing it. So in terms of, if you could highlight, how things are being done, how services are being provided.
Considering India, we have primary, secondary, tertiary level care health system. But definitely, if we have to think that this healthcare system has integrated maternal mental health services, we can say, considering whole India, it's very, very minimal. As Prabhama mentioned, we have very minimal in Kerala, though we haven't started very actively or proactively, but we had involved in training, we had provided training, we had policy, but maybe because of the COVID, we couldn't start actively. But the system is, the plan is educate and train the junior public health nurses and medical officers regarding this maternal mental health. And the junior public health nurses screen the mothers and refer to the medical officers or the medical officers or mental health professionals in the district mental health program. So this a system of care is named as in Kerala Amma Manasa. But yes, even in Kerala, we have to go far, we have to get long, and we have to make it very actively. So it's not at, clearly started. And yes, as mentioned, asking about mothers' mental health, mental illness in Karnataka, Chhattisgarh, there are some levels of some activities being started, but not yet actually integrated, not yet actively given. And also, it is very important to integrate maternal mental health care in the general maternal care. So, though our union ministry has come up with various programs, Janani Yojana and Sukriti Yojana, Samvi, all those things, but it's not yet started providing or addressing the maternal mental health in that way. If I say, for example, DMHP, almost all mental health professionals in Kerala and district mental health program being trained in maternal mental health. As I said, though the whenever cases are coming, they will be addressing the cases, but there is no series of the services per se, not yet completely started, particularly focusing the maternal mental health. And also, yes, we have taluk level, district level, and state, sometimes in state level or medical colleges where we have psychiatry facilities and where the mothers are getting care. But per se, again, I'm repeating, typical maternal mental health services is not yet started like in our name hands. And also, we can say that a very tertiary level, advanced level of care being provided in enhanced mother baby unit as part of our perinatal psychiatry, perinatal mental health services. And also, we have different models of care, and especially telephonic helpline that NIMANS we have started long back. Mothers who are discharged from here, the mothers can call at any point of time, 24/7, our helpline provided to the mothers who are getting discharged from the psychiatry wards. And also, some hope is there that some Indian Psychiatric Society has a separate chapter to deal with maternal mental health. And I think like this, the Nurses Association, Psychologists Association, social workers, all people should have this kind of chapters to deal with or to handle and to train, to orient their concerned professionals in maternal mental health. Also, one good thing in our state that we have going to start one mobile application for mothers. It will help them to screen themselves a PDS is translated into Malayalam, they can use that. Also, one more psychosocial assessment checklist being validated, and they can use this checklist. It is a culturally appropriate one, adapted one. They can screen themselves, and even Anganwadi workers or the healthcare professionals can use these apps. And also, yes, maternal mental health, we have to mention, or we have to focus the child's mental health, infant's mental health as well. So for helping mothers, we have developed a screening checklist for mothers, for parents, that they can apply for their children's screening as well. So in nutshell, we need to consider, we have some levels of systems, primary, secondary, tertiary, but not yet equipped to deal with the maternal mental health, though very minimal services are available, and some states still we need to do a lot. And as a social worker, I think I have to mention some more points here that we need to mention. The developmental perspective of maternal mental health care, that is poverty alleviation program, enhancing literacy and education among women, and also other women empowerment programs, also dealing with gender violence. So with this, I would like to conclude my points.
Yeah, thanks, Rakesh. I mean, I think the point you made about training various professionals, already there's a lot of discussion going on about the barriers in training healthcare professionals in maternal mental in the chat. So I think we'll come back to that question. I think it's very important that, so what I understand is there are pockets where, the services are available, where some states are doing it, and the question will be, will it benefit all the mothers? Because women come from different backgrounds, different cadres of socioeconomic status or literacy. So many variables are there. So how do we plan a comprehensive maternal mental health care? So let me move on to Dr. Saroj from Nepal. So Dr. Saroj, I think we keep talking about cultural barriers. What do you think in terms of in Nepal? I do remember reading some interesting postpartum rituals in Nepal. So how do you think, maternal mental health in this kind of a scenario, how do you think culture influences maternal mental health?
First of all, thank you very much, Professor Geeta. Thank you and namaskar from Kathmandu, everyone. And this topic, maternal mental health, I think I'm really quite impressed by the presentation by the Professor Prabha Chandra. To me, maternal mental health and maternal mental health problem, these are the two things I think we need to understand. Not only the medical professions, I think the people and the policymakers, they should know the importance of what is maternal mental health and what is maternal mental health problems. I think coming to the points, the cultural factors that influence maternal mental health in Nepal, I will talking about first the background of Nepalese culture, and then it has the positive aspect and it has the negative aspect. That is what I'm going to try to share with the audience. The first thing, the culture of Nepal is enriched with the diverse culture. I think there are 125 ethnic groups. Within these ethnic groups in Nepal, there are 80% are Hinduism and Buddhism are 11%. And within these religions also, we worship many gods and goddesses. We celebrate a lot of festival with belief in existence of gods and goddesses. These beliefs are extend into our daily lives, the way we perceive health, disease, and disorder, especially in the rural part of our country. Disease and disorder are still viewed as scenes of the past lives and also influence of demons or evil energy. So our culture beliefs are supported. The only men are allowed to cremate the lost family member. The women are supposed to bear a son and do the household works. Menarche is still viewed as a sign of impurity, and the girls at Menarche are forced to stay in isolated room and some of the rural parts even stable. Access to educations for girls are still few. So with this, the backgrounds of the cultural factors, these cultural factors have negative influence, especially the maternal mental health. Number one is women during pregnancies aren't looked after. The household works, including feeding domesticated animals, and their main responsibility. And number two is keeping all aside, the mental burdens to bear a son is always there. So the neglect and the mistreatment which are happening in the rural part of our country breaks down the women's living there physically and emotionally, and that breaks the women's as lack of confidence, lack of empowerment, and that makes further the vulnerable to the mental health problems. And as already discussed in the panel, already, depression, anxiety are the common problems, especially maternal mental health. In Nepal also, the pregnancy, 13% women are suffer from depressions, and depression is said to have 10 out of every 100 during pregnancy and 13 out of every 100 after childbirth. Besides these cultural factors, the laws in Nepal aren't helpful too, as women who have mental health problems can be divorced easily without any hassles. As we believe in supernatural theory, seeking health care is not the priority. 1/3 women have access to the care. 1/3 of women have access to trained skilled birth attendants, and the problem is even greater if the those pregnant women having mental health problems, they will suffer from antenatal and postnatal problems. Over the decades, maternal mortality is decreasing because of the improving physical health, access, and ability. However, the postpartum maternal mortality is still one of the major cause of the suicide is increasing, and one of the major cause of deaths. We have still the maternal mortality is 239 per 100,000 live births. Hierarchy in the ethnicity is still another practice in our part. Still, there are some of the caste system are there, and some of the castes are regarded as untouchable still. And women are even more mistreated or abused, and getting into school or work is difficult for them. So these are some of the direct and indirect factors that indirectly, directly the vulnerable groups especially for the female. In other hands, we have some of the positive cultural factors that has the positive aspect. For example, we have the culture of living in the joint family. That is one of the resilience positive factor. The culture of providing the massage to the baby and the mother is another positive factor post-delivery. And the provision of nutritious food to energize the mothers and promote the breastfeeding is another positive aspect. And celebrating following delivery as a naming ceremony or as a weaning ceremony is another positive aspect. So with this, I think all factors, these factors will provide the sense of well-being to the mother, and that will uplift the confidence and enhance the well-being. So these are the things which I think Nepal, the positive and negative aspect. But of course, the maternal mental health problem is the time we need to raise the voice, and we need to talk, we need to discuss, and we need to create the awareness, not only the people, among the people, and I think among the policymakers also. Thank you, Professor Gita. Professor Gita, can you unmute?
You made two good points. One, I thought, I think we should not be looking at only the disorders per se, and look at health, like how we look after physical health, being nutritious, eating nutritious food, exercise. And I think what is it that we can do to enhance mental well-being? I think that is one point. The second thing is, I think sometimes cultural factors influence how women present with certain depression or anxiety. So sometimes screening using certain methods of certain scales might not be very useful. So they have different ways of presenting. I think that is another important aspect that we need to think about. And I think you also talked about various factors that actually influence women being aware of their mental health, as well as seeking care for the same. And I'm very sure that one program we cannot really, it will not suit all the areas, because we really need to target. There are high risk population, there are women from different backgrounds who need different kind of care. Probably there are different levels of care that they need. I think that's a very important points you raised. Are there any screening initiatives for maternal mental health in Nepal right now?
Thank you, Professor Geeta. To improve this type of the mental health programs, Nepal government has been moving towards the implementing national mental health policy. We have the national mental health policy, which includes the improving the overall access to the mental health, especially in the rural community. With the support of government and the NGO, the midwives are being trained in normal delivery and also screening of the mental disorder. So including midwife, not only midwives, the paramedics also. If we train the screening for mental health disorder, probably the mental health problems can be addressed. The another point is in our Nepalese law, human right and equity has been enforced by the Nepalese law. Similarly, the education and awareness is increasing. Especially these are the barriers, especially that barriers, if we educate, if we are aware, probably the barrier of upper and lower caste, that will be disappear probably. And another important point is the raising mental health awareness program. That will be another program. If we use different kinds of news media, or we use the videos or the radio programs, probably we can aware the people. And as I already told, the maternal mental health, the concept of the importance of maternal mental health is very important. The people understand when we talk about mental health, the people still understand the way the people understands looking after mental illness. But if we aware people regarding the importance of maternal mental health, probably I think we can address the issues which we are planning to address. Thank you, Professor Geeta.
Thanks, Dr. Suraj. And also the highlighting some of the positive points that the culture can also bring into improving maternal mental health. So now we've had 3 panelists from the mental health profession background. So we move on to the obstetrician. I think it's a pleasure to have Dr. Srinivas here. So Dr. Srinivas, I think you've been hearing all of us saying, training obstetricians and what is it that, can be done. And so as an obstetrician, so what do you think need to be done for maternal mental health? And do you really, we've been discussing so much about the problems and, the solutions. So what is your perspective on this?
Good morning, all. First of all, I would like to thank the organizers for this opportunity. It's great to be amidst all the psychiatrists. I think I'm the only obstetrician panelist, plus probably in the audience also. I don't think too many obstetricians are there. The first time I saw, when I was included in this panel, I was just looking at the incidence of mental health illness in the perinatal period. 10 to 20% is such a great number. And we have deliveries almost say 15 to 18,000 per year. Ours is one of the institutes in South India, wherein I think it is second or third in South India, catering to such a big number. And hardly we refer 1 case or 2 cases a month to the psychiatrist. So this is one thing which really surprised me. If the incidence is to be 10 to 20%, we should have had at least 1,000 patients in a year minimum. But this is something which is not there. Probably one thing that I attribute this is to the awareness. including me, I would be very honestly telling, for the past few years, I have taken little extra interest in the maternal mental health. Quite a problems in the perinatal period. Especially, we had one on impulsivity in case of empty pill abuse, and another paper on post-traumatic stress disorders, including episiotomy, cesarean, etc. And then I became a bit aware of these problems. As everyone is pointing out, the biggest problem, except in teaching hospitals, would be the availability of psychiatry service. And the moment you ask a patient to go to a psychiatrist, probably in Bangalore, we refer them to Nimhans or some psychiatric. I think the stigma associated with that, nobody would be willing to do so. And even in our routine rounds, if a patient is crying, if the patient is gloomy, what we say, oh, probably she's exhausted. It is all related to the hormonal changes in pregnancy. This is how most of the aspects of this mental symptoms are neglected or dismissed by us, the obstetricians. And there was a question raised by one of the audience, that how you can train the healthcare workers. I think before training the healthcare workers, it's high time that we start including this or giving more importance to this in our curriculum. I'm both an academician plus a clinician. So we hardly teach our students anything about the perinatal mental health. The other issue that's a government policy which has really come in the way of picking up the cases or treating them would be the discharge policy of the mothers. Though in Western countries, they encourage a lot of home deliveries, it's very important that in our country, every woman delivers in the institution. Institutional deliveries are encouraged. So we have ample opportunity to pick up the cases, but 48 hours is the time given to most of the normal deliveries for discharge. And as I understand, most of the mental illness will manifest probably after 48 hours, 72 hours, sometimes as late as 6 months also. So it needs a lot of work from the baseline workers, from the community. People should probably pick up these cases and help in solving these problems. High risk identification probably should start from the antenatal period itself. I think Dr. Prabhachandra also mentioned that they had to struggle for 5 years to include a couple of questions in the maternal child card, which probably is pertaining to the mental illness. I think this should become a routine. And the Edinburgh scale or Glasgow scale, all these things are Greek and Latin to us. We don't know what are these things. So like we include the partogram or consent form in our case sheets, why shouldn't we include these things in our case sheet routinely, so that at least looking at that, we should be able to do something to our patients when we have such a big number. Fear of medications, continuation of treatment for a long period, and of course, a lot of family problems associated with psychiatric illness, I think also act as barriers here. And assessments tools, probably, I don't know if you people have worked on this, whether the same Edinburgh scale or Glasgow scale is validated to our Indian population, especially South Indian population. I'm not aware. Probably this needs a bit of mutual discussion, and some kind of conclusion has to be arrived at. And I think most of us are concentrating on the late pregnancy, delivery, or the post-delivery period. I tell you, one of the very important period of pregnancy is early pregnancy. I think I want to stress this more. Infertility, then recurrent pregnancy loss, not even recurrent, even one pregnancy loss could be such a traumatic experience for our women, that mental health issues can start getting into their life from the very early pregnancy traumatic experiences. And here there was one more point that was raised about men, participation of men. I would like to stress, nowadays I'm seeing a lot of men more anxious than their wives. So I think it is there is a kind of change that is, there is a little shift towards this. I think you should view them as couple rather than telling perinatal mental illness for only the women. So many a times men require a lot of assistance. And psychiatrist versus obstetrician. See, there is a tendency in obstetricians that when there is a PPH, for example, I would really feel guilty. Is it something that I did wrong and there is a PPH for this patient? So I'm not ready to accept that my patient had PPH. I would always dismiss, no, this is not PPH. It was a very small amount of bleeding. Similarly, if my patient has some psychiatric illness, probably I would not accept. I myself have a tendency to dismiss this, that this is normal, don't worry, and I would probably send the patient back home. So I think as I would be thinking of some solutions, especially for this panel. I just spent some few hours to think what can be done in an academic institute or in the peripheral areas. Awareness creation, inclusion of these problems in the curriculum, and early referrals. Once you are able to identify, a quick referral to the ideal person is something that is important. Availability of the service, accessibility to the patient. Of course, affordability in a government institute may not be a problem, but otherwise affordability also becomes a problem. And of course, acceptability is a big issue. And many of our patients may not, even if I refer, they may not reach you on time. And assessment tools, awareness in the baseline workers, especially the ASHA workers or the junior health assistants. Of course, they are overburdened with most of the programs. I totally agree, but a couple of extra questions should not really burden them. One more extra point that Prabha Madam wanted the obstetrician to address was the confidential inquiry into the maternal deaths. For the past 15 years, I am involved in the maternal death review of the Bangalore Municipal Corporation, that is BBMP, plus the hospital deaths. I have not come across a single case reviewed because of suicide. So this is one more, I think it's an irony. So many things are happening, but I am not able to really know why this is not coming into the discussion at all. So we are only concentrating on hemorrhagic deaths, septic deaths, or some traumatic deaths, and these are the things that are going on. So, but confidential inquiry does happen, but it is more of a defensive inquiry. I just want to say that I was perfectly fine, nothing went wrong. I think this needs a real shift, and a real inquiry has to happen. This happens at two levels, that is at the facility and at the community. I think community level has to take an upper hand to look into these aspects of mental health. And I think with these words, I think it's time also for me. These are my thoughts about the perinatal.
No, I mean, I think you brought in very, I mean, you know, it's also sometimes psychiatrists versus obstetricians. I think it should not be that way. It should be psychiatrists and obstetricians, because I think it's very essential. And how much an obstetrician PG resident, you know, should be aware of perinatal mental health, and what are the things that can be treated by obstetricians themselves. You know, not everybody needs to go to a psychiatrist, because that is the point that you highlighted, that referrals are made, but they don't reach. So what is it that, you know, obstetrician can feel confident about, you know, handling distress? Many a times mothers might just feel talking to an obstetrician, you know, more useful. So I think, you know, we need to really have this whole idea in mind, that it should not be just belonging to a psychiatry or mental health professional, because probably mother's mental health, maternal mental health has so many varied representations of varied health professionals. So all of us should be on this together and see how best we can work towards enhancing care. And I think you brought out a very important point. Often we get defensive about certain things, and I think it's for us to actually reflect upon and see how we can improve on that. I think it's a very, there's a lot of simultaneous discussions going on in the chat about training and other things. And you also brought in a very important point. I think that is father's mental health. And I truly agree. We've started having some services for the fathers at NIMHANS because I think they should be part of this whole treatment. There's no doubt about it. And there is enough literature in the West about fathers' perinatal depression. But however, somehow we haven't had the focus, at least from this region. I haven't seen too many papers on fathers' mental health. So I think it's a very, very valid point. Thank you so much. So I I move on to Dr. Siham.
Yes, Dr. Geeta.
Yes. So yeah, I mean, I think now there have been a lot of points that have come up. So I just wanted to ask you in terms of, so much of research is there. I know that there are good quality studies, randomized trials about maternal mental health screening. N number of studies are there in terms of prevalence. So according to you, what do you think is the barrier in getting all these findings into policies and improving the care?
Thank you very much, Dr. Geeta, for posing that question. I think there's no straight or simple answer to that. So I'll start with a couple of points and see if they resonate, and if this initiative of South Asian Marseille's society can also sort of leverage that in sort of bringing that more to highlight it. I think there are a couple of things. One is you're absolutely right. Since the last 15 years now, we know that interventions delivered through non-specialists, non-specialists in terms of mental health are feasible and they're effective. So there's ample body of evidence. I think the gap is how do you scale these up? And when you get into the scale up and you bring in the implementation science, it poses a very unique and very different set of questions. How do you navigate the policy environment? How do you navigate reaching across a larger population? So immediately your intervention scope changes, you start interacting with multiple organizations and multiple systems. So I think we should invest in building implementation research capacity across the region. And I'm very proud to be part of that group, at least from Pakistan, and from that we've been trying to leverage funding and grants to try and build implementation research capacity within South Asia. I saw Dr. Prabha mention a couple of studies in her presentation. That's a small testimony that we've been trying to work across Nepal, Sri Lanka, Bangladesh, and Pakistan, and India as well, to try and understand how to bridge this gap of taking things to policy and practice. So implementation research capacity is one. I think we should also, another gap is collaboration. So cross-talking with other countries. So I hear from so many of our esteemed panelists talking about so many things which are so similar in Pakistani context. I'm working very closely these days with Sri Lanka, Bangladesh, and Nepal. I see there are unique similarities, and there's so much of potential to learn from each other. So, for example, very quickly, from Nepal, I know that female community health volunteers are being launched. In Pakistan, we've been working with peers. We've worked with peers in India as well to try and deliver perinatal mental health intervention. We picked up community proactive detection of maternal depression, an approach that was developed in Nepal. We adapted that in Pakistan. So there are many synergies and unique points to learn from each other. So for example, in Sri Lanka, they're thinking of tasks shifting through medical graduates. So that's another sector that they're trying to involve and see how can they address perinatal mental health within the community settings of Sri Lanka. Similarly, from Dhaka, Bangladesh, working in slums, how do you navigate such populations is an important learning aspect, at least for Pakistan. So just to summarize, I think we should collaborate more. We should invest on research capacity building and strengthening, especially around implementation research. I think as mental health or allied health professionals or obstetricians and specialists in our own respective fields, I think we also need to invest in developing and strengthening capacity on how do we engage with the policy environment. I think that's a gap. And for at least for mental health professionals like me, I trained as a psychiatrist, but since the last 20 years, I'm in global mental health and I've been interfacing with the policy environment. But specifically having capacity strengthened in health diplomacy, how do you broker, how do you translate, how do you push for policy change? I think that requires a separate set of strengths and understanding. So I think these are some of the key things that come to my mind in terms of trying to bridge this evidence to practice gap. Obviously, there is merit in trying to put up all the evidence around any social innovation. So peers is a social innovation. Use technology. I think technology should be used to our advantage to try and scale up things, inform the policy environment, that you can do a lot with through technology, and you can scale up, you can task shift and task pair. So those are my thoughts in terms of how to bridge this research to practice and policy uptake gap. Hope that answers your question, Dr. Geeta. Perhaps we should also think with the SDGs and with the universal health coverage being one of the key areas. At least Pakistan is trying to leverage and ride that tide for mental health, especially for maternal mental health. So I'll stop here. If you have any queries so I'll be happy to elaborate on that.
So, I think it's very important that, there's a lot of commonalities that among all these countries, and probably the services are also at almost a similar level, that there are, some have started, some haven't, struggling to start and sustain. So what has been your experience? You're part of a randomized trial in terms of, having the volunteers, peers, isn't it, peers? So when you take these, findings to the policymakers, and what do you think? What is your experience in Pakistan?
Thank you, Dr. Geeta. I think that's an important question, and especially from Pakistan's perspective, I think we've been working in Pakistan since the last 20 years for perinatal and maternal mental health. It's not been an easy journey, but now I think there are a couple of important things that Pakistan as a state started understanding, and I take a little bit of credit in terms of sensitizing this space, that maternal mental health and mental health is important. We all know mental health is still neglected. So for Pakistan in the last decade, there has been some important things that have happened. So for example, for the first time in Pakistan, NCDs and mental health program at the ministerial level has been launched. This came about by us becoming a signatory to WHO's EMBRO region's mental health framework. More recently, since the last 7 years, at the highest policy level, the Director General Health of Pakistan, as well as the State Minister of Health, State Minister of Health, have been champions of mental health, and we got to invest on them. One comes from a background of health diplomacy, and the other was a pediatrician, but they both were mental health champions, and we saw that opportunity to invest and broker more buy-in and create more visibility around the work that we had been doing. So for example, Thinking Healthy program, Dr. Prabha mentioned Professor Atif Rahman. So the Thinking Healthy program, which is a WHO intervention for perinatal mental health, was developed and tested in Pakistan. So having that pool of evidence, this combination of the state trying to get sensitized with mental health, as well as this opportunity of mental health champions sitting at the right posts. I think this recipe came together where now we have a president's program. 2019, August, the president of Pakistan announced that the office of president will back promoting mental health of Pakistanis, looking into innovations, for example, technology, especially technology, to promote maternal mental health as well as school mental health. So I think we've been fortunate that we had a little bit of evidence to back our claims. There were people in the right posts at the right time. So thus I say that, in my opinion, there's a gap. We should invest in strengthening how to broker policy change and how to work within policy environments, because there's no one person who's responsible for policy change. It's not the minister, it's not the DG Health. It's a group of, it's an environment where you have to interact and navigate. So that's, I think Pakistan has been fortunate in terms of our hard work that it's now coming to highlight. And the journey doesn't end here, Dr. Geeta. Yes, Thinking Healthy program and evidence-based intervention. We know from a couple of our ongoing work, we have a Bachpan cohort going on with depressed women, following them up since pregnancy to now their children are turning 8 years old. We clearly know that only Thinking Healthy program may not be the answer. We are working simultaneously on collaborative care programs for maternal depression, because intimate partner violence is quite rife. So there is this stressful environment amongst where the women reside. We're learning from Nepal's suicide prevention program. We're now just kicking off a suicide prevention program in Pakistan. So we're constantly innovating, even in Thinking Healthy programs. We're technologizing this. We have a trial starting now in a couple of months, where we're using peers, lame women, to use technology. Can we leverage technology to reduce the effort of training and supervision? And through technology, standardizing the content to leverage more fidelity of the intervention. So, trying to innovate, reduce the burden. I think Dr. Aisha from Pakistan raised, how do you train people? How do you integrate? So we're trying to innovate, constantly trying to innovate and titrate our even existing interventions. So there's no stopping there. How do we navigate and address IPV within this perinatal population? How do we engage men? I think these are the kinds of social and technological innovations that us as researchers, public mental health researchers, need to constantly do, yet keep engaged with the policy environment. So I'll stop here. So over to you, Dr. Geeta.
I think, thank you, because I think it's important to, understand the processes involved in getting things going, because yes, there are policies, there are studies, but how do you, get them to actually work together? So I think it's important to have all the stakeholders and get the right people who are, going to take decisions, or, I think that's very, I think for me, this was a very key thing, that research is there, but it doesn't, materialize. But I see that, changes have come through. So thank you. Okay, so our last panelist, Dr. Aruni, I think I am going to take a little different questions for you, because I know that, we're just talking in terms of mental disorders and, promoting mental health. But we know that, the trauma, especially trauma, again, we talk more in terms of individual trauma, but here I'm talking about natural disasters, war, conflicts, pandemic now. So what has been your experience in terms of providing maternal mental health care and in Sri Lanka?
So first of all, I would like to thank Professor Prabha Chandra and the team for inviting me as a panelist. To answer your question, Professor Geeta, now especially since the Easter Sunday bombings of 2019, we here in Sri Lanka have been experiencing one disaster after the other. So it has not been quite an easy path here for the people of Sri Lanka. Now, in terms of my experience regarding maternal mental health services, I will highlight what the experience we had during the COVID outbreak, especially during the second and the third waves in late 2020 and 2021. Here in Sri Lanka, we have 25 administrative districts. Each district has at least one fully equipped obstetric unit, as well as an inpatient acute psychiatry unit, which are manned by board-certified consultants in that respective area. During the COVID period, at least some of the beds in these obstetric units were dedicated to COVID-positive perinatal women. For example, in the hospital where I work, we had an entire unit dedicated to COVID-positive women, either in their antenatal period or postnatal period. So if a woman was admitted who had a history of psychiatric illness, or who had symptoms of a relapse, or if the obstetric team was concerned about the psychological well-being, these women were referred to us. So we initiated treatment either in the obstetric unit itself, or if she was to be discharged, we initiated treatment in the community with the help of the community teams. However, if she needed acute inpatient psychiatric care, especially in terms of electroconvulsive therapy, then we had problems because of the lack of resources. Even though some of the units do have electroconvulsive machines, and we have several mother and baby beds, especially there's a unit at the National Institute of Mental Health, which is dedicated to mother and babies, where there are 8 beds. And in the hospital where I work, I have 1 bed. However, none of these beds or the units had the facilities to give ECT to COVID-positive women. So we had to transfer these women to the National Institute of Mental Health to receive ECT. But we had to separate the baby and the mother, especially if this woman was in the postpartum period, because these mother and baby units did not have facilities to manage a COVID-positive neonate. So that is what we did for patients who were admitted in hospital. As regard to people who were in the community, now we have here in Sri Lanka, more than 90% of the births occur in government hospitals. So these women are followed up by a team of people whom we call primary healthcare team, who are mainly public health, medical and allied health workforce team. So it consists, the team consists of a doctor, a public health midwife, and a public health nursing sister. So these people were trained to detect, and also were being made aware that there might be a high incidence or prevalence of relapses, what is stress, how to identify it, and also that the possibility of high prevalence of domestic violence and its impact on the mental health of these women. So the Family Health Bureau, which is the primary organization which supervise these public health teams, took this initiative, which I think is quite commendable. In addition, we also had certain other initiatives like having hotlines for these women to contact us directly, but I'm sure that some of the units did not have this facility. The central unit at the National Institute of Mental Health, when they received the phone call, directed it to the regional psychiatrist. But some of the units did have hotlines, which was a facility which we provided. In addition, we also provided some educational programs over the media as well as social media to educate women in their perinatal period about how to identify stresses, anxiety, and mental illness. Now, here in Sri Lanka, we do have the validated Edinburgh postnatal depression scale, which is used by the primary healthcare team, which I used, but it does not detect all the mental illnesses. So one of the things which we did was actually educate them. No, there are other mental illnesses, anxiety disorders and things, but I'm not sure whether we did achieve everything, because it's a huge burden on these primary mental health care teams to deal with. Just not, they are not just dealing with the mental well-being of these women. They have to look after the physical well-being as well. So those are the experiences I've had. However, I must say,
Dr. Aruni, can I just, sorry, I just wanted to check, did you also screen for any stress-related conditions? Because these were women who could have been exposed to other kinds of, situations as well, conflicts, war-like situation. So is it like constant, do you screen them even for PTSD and other things? Is it?
So if they present to us, we do ask.
Okay.
However, we do not have tools apart from the Edinburgh postnatal depression at the moment. We are actually developing a tool to detect anxiety and other things now, which is still in the validation phase, unfortunately. So,
okay. No, I think for me, I just
having said what I said, yeah. So we did try to adapt and adopt new strategies to provide the services for our people, but there was this lockdown, there were travel restrictions, lack and scarcity of medication. On top of that, I think some of the times what we found was there was this lack of communication between the teams, the psychiatrists in the hospital and the primary mental health care team. And also something which the other panelists also highlighted, the cultural factors. So especially patients in the perinatal period and their families do not believe in this concept. They have these cultural beliefs as to why mental illnesses, these things occur. So it's a huge burden which we encountered, especially during the COVID period. In fact, what I can say is during a psychological autopsy of maternal death, it's a fact which was highlighted because the woman did not believe she had a mental illness, nor did the family. And the other problem we have is the Archaic Mental Health Act. The last amendment was in 1956. The new act is still in a draft state. So it's very difficult for us to provide optimal care, and it's difficult for the patients and their families to receive optimal care in this background of various cultural beliefs and archaic policies.
Okay, thank you. But do you see that, mothers who present soon after these conflicts, do you get to see more women with any PTSD symptoms in the mental health setting?
We haven't seen an increased prevalence. I actually don't have data to that. Okay. So it's difficult to say. We see the normal sort of presentations currently.
Okay. Thank you. I think I would request all the panelists to have their videos on, so that I think, at the end of all the panelists have given their discourses, and then they've discussed about the various points. So few things that I feel have been very well said and put. One, there's a lot of commonality. So we have some common goal to work together. I think that's the biggest point that I take from this, that we have a common goal to work together. The second point that is also highlighted is it's not just about treatment of mental disorders, but also in terms of prevention and promotion of maternal mental health. And again, understanding how health systems function in each of these countries and developing interventions which are evidence-based and easily culturally acceptable. I think there's a lot of discussion on what the barriers in seeking treatment as well as barriers in even addressing mental health problems. I think this is very important, but it's very wonderful to hear all of us are actually sailing in the same boat. We all have faced the same challenges. And I think it'll be, and I thank Dr. Prabha. I think she's been answering all the queries in the chat box for and keeping the chats coming in. So do we have time for any questions to the panelists? I think some, Dr. Siam actually answered some questions in the chat. Ashlesha, can they?
We have about 10 minutes if you wanted to take any questions.
Okay. Any questions to any of the panelists on what has been, discussed? Let me see if I.
There's one question on post-traumatic stress and abuse. So maybe
I thought
Aruni has kind of addressed it, but
yeah, I've just seen that. Yeah. Yeah, I think Aisha has actually talked about I think commented on abuse, need for screening for PTSD, but I think it's also an important question. One thing which we didn't, culturally sensitive tools. I think Dr. Srinivas raised that question that EPDS, has it been standardized in various countries? Are the cutoffs available? There are questions related to, is it acceptable tool to all women? So I think PTSD screening. So should we, the next question for all of us is PTS something which PTSD symptoms, are they different in this specific population? Should we make it mandatory to screen women, at least post certain situations like COVID or a disaster or other, crisis situations? So as of now, I think most of the studies that I have seen in South Asia are all using the standard DSM-4 PTSD symptom checklist. So there's nothing specific. So other thing that I also wanted to highlight is about different ways of presentations, more so in terms of women presenting with a lot of physical symptoms which do not get identified as depression, I think, in our cultural setting. So I think this is something that we all need to think in terms of, cultural developing, having our own culturally validated tools, as well as, and not just about depression and anxiety, but also extending it beyond, depression and anxiety is also something that is very important. I think I'm not seeing any more questions. Okay, sorry. Okay, Sonali has a question regarding the commonalities that you just highlighted between the different countries. What would be the best way to start to collaborate in the panelists' view? Okay, Dr. Aruni, you would like to answer this?
I think the way to go forwards would be for us to have a discussion regarding the symptomatology of various mental illnesses. Like I heard Professor Sarosh from Nepal telling about the cultural impact of various maternal mental illnesses. I'm sure most of us share almost the same cultural things in South Asia. So whether there are differences or similarities. So in order to do that, I think we need to get together and look at various symptom patterns of various illnesses, especially during the reproductive age group.
Dr. Siham, you wanted to, yeah.
Thank you, Dr. Geeta. I think the way forward to collaborate can be in multiple ways. One is whenever any of the countries are putting up grants, so think regionally. So we have examples, so SHARE, which was an NIMH, South Asian funded hub from the National Institute of Mental Health, US. Currently, myself and Atif, we lead another initiative funded by the UK National Institute for Health Research, and we're working across the region. So I think that's a brilliant way to collaborate and bring in regionality. And now with this chapter being launched at Marseille, I think this should also provide that kind of forum where people can try and collaborate and cross-learn and cross-innovate. So I'll stop here if that answers.
Yes, Dr. Siham. I think, probably this chapter should provide a platform to collaborate and, do more research and develop more evidence-based interventions specifically to this region. So there's another question on miscarriage. How do you address miscarriage as maternal mental health? I request Dr. Saroj, would you like to take this question?
Thank you very much, Professor Geeta. I think, the events happens to us. How you take it is very important aspect. If you take it positively, probably our mental health will be positive. If we take it negatively, then our mental health will be negative. So everything, I think, depends on our interpretation also. So the most important part is, I think, if we are taking any events as a stress, that stress might be positive and a negative. So if the stress becomes distress, then we need to manage it. So the important part is, I think, especially my wife is also a gynecologist. I used to share my experience with my wife regarding the psychosocial issues. For example, if the gynecologist if they hear the problem of their clients or patients, if they ventilate their emotion, probably that is sometimes enough to prevent from some kind of the psychological adjustment problem or maybe the stress reaction. So to me, any kind of events, what happens to anybody, probably if we take it positively and if the treating physicians have time to listen and give some kind of technical advice, probably that will address the problem.
I think, thank you, Dr. Saroj. I think we don't really have, there's so much we talk about mental health, the whole area of perinatal loss and responses, they're so culturally very different and how it is addressed. There's not much of data in terms of how we address it, because the routine screening is not done in terms of when a woman has a miscarriage, whether routine screening for mental distress, at what level it should be done. So it is not there, but I think you've raised a very important point. How we respond to a loss, perinatal loss, is something that I think all of us, we really need to think. But there's we're just looking at some of the, how cultural practice, how grieving is there, is it promoted? Grieving is promoted in certain countries. Actually, perinatal grief, I think, is an area which is not really discussed very often in, at least South, whatever I have come across, I don't think much is there. But I think it's a very important point. We need to really, address it. I just wanted to ask Dr. Srinivas, what do you think about, because we're talking only about pregnancy and postpartum, what about miscarriage? Do you have any additional point to add to it?
Thank you, Dr. Geeta. I think I raised this point that early pregnancy mishaps, it could be abortions, it could be ectopic pregnancy, which again causes a pregnancy loss, or molar pregnancies, whatever it is, when the outcome is not a welcome outcome, we definitely have patients with so much of grief. And I slightly differ with Dr. Saroj in this, because almost everyone who wants to have a baby would not have a positive attitude towards these things. We always get paid. It is always the obstetrician or the attending physician who has to who has a big role in making the situation slightly positive. I don't think anybody comes to us with a positive attitude with these things. So this has two types of effects. One is for that pregnancy, and for future conceptions also, they have a lot of issues that, like whether I would abort again, whether this kind of things will repeat again. And this anxiety continues for a very long time. It could be anxiety reaction, or it could be something else also, whatever you name. So it's a long-term problem for these women. And there was a point, I think, in the chat box that everyone would be included for 1 year after some pregnancy event. That was someone who had just commented there. I think that's a good idea, and they need to be screened, and you have to address this kind of problem.
Yeah, I think, thank you. I mean, what I see is, again, like I said, that, I think we need to move away from illness model. In fact, what we have talked about is only about after a woman becomes pregnant. I think we need to start looking at young women, their reproductive health. It should also include mental health. And I think it should start actually preconception and then move on to conception. And another thing that we haven't actually addressed is, women with pre-existing mental illness and navigating the motherhood. I think that's another area that because our focus was predominantly in terms of community-based services for maternal mental health. Thank you, everyone. And I think it has been a wonderful discussion for me to get so many perspectives. We have a common goal, and I hope we will all work together to achieve the same. Thank you. Over to you, Ashlesha.
Thank you so much. This was such a vibrant panel discussion, both on the screen and in the chat window. So I could see that there's a lot of interest being generated. So thank you very much for all your patience and really giving us a lovely view of what perinatal mental health is in the South Asian region, what it needs to be, and definitely what it can be. So that was very enlightening. What we'd like to do now is just take you through what some of the regional chapters are doing in the international field. Because really today our sort of aim is to look at what next. And I'm glad these are some of the questions that we're already starting to ask. How can we, as the clinicians from the South Asian region, how can we become a little bit more active in this field? What do we need to do? So I thought it'll be quite useful for us to look at what is this Marseille Society doing at the international level, and what can we expect, or what should we be thinking about at the regional level. I'm going to invite Ketki, who is a psychologist from TIS and has been doing a lot of research recently in the perinatal field. And Ketki will help us, lead the next discussion. Purnima, who you all met earlier, and myself will just give you a little presentation on what Marseille Society is up to, and what are their guidelines really in terms of what do they expect regional groups to be doing, and if Dr. Prabha and Dr. Geeta can also be part of that discussion, that would be good. So Ketki, over to you. I'm just going to get my slide set ready.
Thank you so much, everybody. So now we would like to invite Dr. Ashlesha to sort of take us through what the other chapters of Marseille societies are doing.
So can you all see my slides?
Yes.
Yeah. So we are also going to hear from Dr. Louise Howard, a special message that she sent us. So she'll tell us a lot about the International Marseille Society as well. But really, this was a society formed in the 1980s, originally from the UK. And it is a very, very unique organization that has, sort of across specialties. So it's not limited to psychiatrists or only mental health professionals. It includes obstetricians, social workers, psychologists, midwives, consumers. And really what they focus on is a lot of these are their verticals. They have special interest groups. And I was listening very keenly to, us talking about fathers. So they have special interest group that actually bring together professionals who are working with fathers, include fathers who've got experience of, either being a caregiver to someone with perinatal mental health issues, or being themselves struggled with navigating the perinatal phase for their family. They also have special interest groups for pregnancy loss and neonatal death, concealed pregnancy, infertility. They have a special interest group for reproduction forensics. So there are so many special interest groups that meet throughout the year. They also have a biennial conference that happens every 2 years. And they have special meetings for the special interest groups as well. One of the most exciting things, though, then I think Ketki and Purnima and Dr. Prabha and all of you who are members of the International Marseille Society will value is the listserv. They have, so we are all added to the membership list, and there are discussions of anything exciting happening all over the world in the perinatal field. Also queries that can get posted and addressed immediately, networking to mental health professionals across the world. That listserv is really, really very helpful. And I think what's also what I'm noticing is that it has been one of the ways in which the world is also getting to know that there is a lot happening in South Asia. And so the listserv is quite exciting as well. They started a mentorship program, which I was part of in the about just before COVID, so about 3-4 years ago, where members have an opportunity to link up with a mentor anywhere in the world. You can sort of list your interest in, say, I'm interested in research, or I'm interested in service development, I'm interested in policy, and you can link up with a mentor who is focusing in that area and can mentor you for a year in the field of perinatal mental health. They also have the conference that I mentioned, and they also have a newsletter that's frequently, upgrades people on anything that's happening in the perinatal, field. The regional groups of Marseille Society, as you can see, our area is kind of, blank at the moment, and that's what we are hoping to change. So there are some really active regional groups, and these are the regional chapters that they have formed officially. UK and Ireland was the first one, and it's the most active one. Australasian Marseille Society is also very active. Then they have some language-specific ones, and which is actually really, really interesting and very useful because, especially something like Francophone Marseille Society brings together all the countries that speak French. And they, apart from just using their language as a common thing, there are lots of cultural things that are common to them as well. And as I heard, as as a South Asian region, we have a lot of commonalities in culture. So I think thinking about what does a Francophone society do might be useful for us to take things forward. The UK and Ireland Marseille Society, they call themselves the UK IMS. And they have, UK is definitely a leading in the, leading country in the field of perinatal mental health. They have an annual scientific meeting, which is quite a rigorous and very interesting research focused, but also clinical service focused meeting. They have monthly newsletters. They have a lot of focus on training and collaboration. And they have their membership is a sliding scale membership. So they can, people can opt for membership with subscription to journals, without subscription, or just to receive information. And of course, they're very closely linked to the International Marseille Society. The conference this year is the year for the biennial conference. And this year in September, it's going to be held in London. So I'm sure the UK chapter, UK and Ireland chapter is going to be very active in their in the conference as well. The Australasian Marseille Society, which I've had the pleasure of attending their conference a few times, they are also very active, and a good example really of neighboring countries coming together to focus on a perinatal goal. And keeping each other informed. I think Dr. Siham's point was very useful, that when we are doing something in our country, maybe we should think of the region. And that's what Australasian Marseille does quite well. So it includes Australia, New Zealand, and Southeast Asian countries, and the countries from the Pacific coast. They have a high membership, and they have done a really good job with collaborating with NGOs, and so they are very active. So there are organizations like, there's a group called PANDA, which is for postnatal depression group, which was started by lay people and peers and health people who had experience of perinatal mental health issues. And there is another center of perinatal excellence called COPE. So there are many of these organizations which are not necessarily coming from institutions, but they're very well integrated with the Australasian Marseille, and they do a lot of work in advocacy. They do a lot of work in education and just building awareness of perinatal mental health issues. They definitely have, like UK also, and other countries that we know of, they have a well-integrated, screening program. They have nurses who are involved in screening and training and building awareness. Their obstetricians are also very, very actively involved. In fact, a very powerful, I think, and impactful organization is called the Gidget Foundation, which was started by an obstetrician who himself had a wife who had a perinatal mental health issue, and he is very active. He offers funding initiatives, bursaries, and he's very active in the Marseille conference as well. So, and it's a separate, he's also been, if I'm not wrong, Dr. Prabha, he's been the president of the Australian obstetricians group. But the Gidget Foundation is like a separate thing that is integrated so well with all the other organizations. They have an annual conference as well, and they offer a lot of training. Some of the points that were raised here, in terms of integrating training. So I think Australia does that. Their child psychiatry program actually includes perinatal mental health. So they have a lot of integrated training. They have the psychologists get access to mother-infant training. Their researchers also are linked to clinicians quite well. So I think from Australasian group, we can really learn about how they integrate so well with people from all disciplines. MONA is the regional group for North American countries. Again, very active and vibrant group. They have an annual conference. They offer a lot of free webinars throughout the year for their members. They have informal peer groups and a network of professionals for cross referrals. So that's, and the Postpartum Support International Group, which is a very well-known organization that was started by a person who developed postnatal depression many years ago, felt like she didn't have any support, and really set forth to building a network of support groups for women in the postnatal period. So they do a lot of training, and MONA is closely linked with them as well. They have a lot of research initiatives, and within MONA, they have a lot of special interest groups. So MONA is another good example of how a large region, so it's all of North America, which is fairly large, how they can link together and work together, in a perinatal field. And they also have a lot of institutional connections. So their institutionals are quite well linked together and collaborative, and not very unnecessarily competitive. It's like a shared competition. We are doing this research. What are you doing? Let's share it together. So that's very heartening to see from the MONA group. Like I said, the language specific Marseille societies are really interesting to learn from, because they are doing a lot of remarkable work in the high cutting edge perinatal work that happens globally gets translated, that gets replicated in local languages. And so French speaking countries are together, German speaking countries, Italian, Spanish, Portuguese, Nordic and Japanese. So I think we can learn a lot from these language specific Marsi groups, because that I feel will be our quite an important area that we'll need to focus on. Especially when I heard all of you talk about, with rural areas and areas where there are limited resources, limited literacy, we are going to have to do a lot of work on regional translation of language, material. And all these specific Marseille chapters are also quite active in their own way in research initiatives, but also clinical services. And they have their own groups. There is a lot of advocacy in legal areas as well, in all these chapters. There are lots of emerging regional groups, and I think Dr. Prabha highlighted the African Alliance, which is not yet a Marseille chapter, but definitely Africa is emerging and doing a lot of work in perinatal mental health. And I think we have a lot of cultural similarities, in terms of how parenting and mother-infant bonding happens. So I feel like we should keep an eye on what the emerging regional groups are doing, and think about learning from them, collaborating with them, and maybe also setting an example for them. Because if we are starting a chapter, I'm sure they would love to watch this space for us and from us, and learn from us as well. So what do we think would be a good starting point? And I'm very excited that everyone is here to start thinking about what next for South Asia. And some of the things that we thought of were for the rest of this year, we would love to formalize and form this chapter, and formalize the operations of the Constitution and the Executive Council. We invite nominations for the Executive Council from all South Asian countries, and we would really like the council to be representative of disciplines from all over, and not limited to psychiatrists and psychologists. We'd like it to be a wide range of people who can make a difference, who have been impacted by, and would love to be a part of the perinatal mental health field. We are hoping to have regular activities leading up to January. The International Marseille Society has a membership that starts in January. So we think that if we can create it exciting, and maybe have activities from each country, that would make it really interesting and exciting for members to start looking forward to something from January, as well as a more formal process. And of course, we'd invite some suggestions for a name. We were thinking, something like SAMA, which is South Asian Marseille Association. But if anyone has any other ideas, we are, welcome. We'd love to have a discussion on that. As you're thinking about these things, I'll ask Purnima now to just go through some of the guidelines that are set aside by the International Marseille Society, so that we can think of, within these guidelines, how do we start thinking of our South Asian region? Of course, we don't have to, guidelines are just guidelines, but it would be nice for us to use that as a framework to start our journey in the South Asian region. Over to you, Purnima. Ketki?
Thank you. So now I invite Purnima to share the South Asian Marseille Society's guidelines. So over to you, Purnima.
Hi, thank you, Ashlesha. I think the majority of the things that I was planning to cover, you had already covered. So I'll just go through some of the points. When I was going through the guidelines, first to establish the aim, I think Dr. Prabha has also mentioned something, on the discussion, and Dr. Ashlesha mentioned about what could we aim for, and what could be our mission by establishing the South Asian chapter of Marseille. And plus, it's not only limited to mental health professionals. So members like pediatricians, obstetricians, midwives, nurses, and other childhood specialists can be a part of this association, so that we have a wide range, and we can work in a more collaborative manner. So some of the things that International Marseille Society has suggested, if you are establishing a chapter, that how to promote it. So one of the things that is to have a website of the South Asian chapter. regional chapter. And like now, because the biennial conference is nearing, it's happening in September in London, so probably like whoever out of us are there attending it in person, post the events, we can have, you know, kind of meeting and promote it there, have conversations about it there, so that, you know, people are more aware that we are in the process of establishing South Asian chapter of Marseille. Along with it, so as Dr. Shlesha was mentioning, that there are some countries where, or there are some chapters which are evolving. So what does that mean? So a chapter is considered to be evolving if it has members which are less than 30 numbers. So once we reach the number 30, so it is, we are an established chapter. So based on the number of members the chapter has, it can be, you know, categorized as evolving or established chapter. Another thing is, like, in terms of, I think Dr. Sikandar was mentioning about, like, you know, how to enroll it in, what will be the fee like, and how to be distributed. So like, you know, as Dr. Shlesha mentioned, that we have annual subscription, and we have to subscribe, or we have to, you know, pay our membership fee to the International Marseille Society. And and there is a range, right? Like, so because like South Asian chapter falls under LAMI, so our basic subscription fee is $20, and then that will also then impact the reimbursement that happens between International Society and us. So generally, the motion that was passed, like in the biennial conference that happened in Bangalore, so what was like established was, like, for example, like if there are countries who are developed countries, so the payment that is being received to the regional chapter, the reimbursement of $30 per member has to be given to the International Society, or vice versa. So it depends upon the members to which they, you know, where they exactly pay. Or if you are a premium member, so 40% will go by subtracting the amount that goes for the Archives of Women Mental Health journal. However, because being LAMI countries, we have a basic $20 subscription fee. So that reimbursement thing will not work for us. What we might have to do is, like, once it's established, we have to reach out to the International Society or the president of the International Society and ask for financial assistance in carrying out the activities, whatever we plan to do, right? But once the chapter is established, we do have quite a flexibility how we would like to function about it. If we want to, you know, carry out yearly conferences, or like, you know, some after 6 months, any kind of workshops or any kind of meeting, community awareness, that is something that we can discuss about in terms of what could be our aim. Like as Dr. Shlesha mentioned, we do have 6 months right now to meet the executive council, or, you know, to establish like what all could be our aims and missions, keeping South Asian chapter and whatever we, you know, learn through our panel discussion, what kind of work is happening around. So this is the basic framework that has been mentioned. So there are no strict guidelines that have been mentioned by the International Society. It's just that now we all have to get together to, you know, just formulate in a way what all we are looking forward from the society, and how we would like to make it relevant, and, you know, how we can increase the presence of this chapter across other Marseille members of International Society. Thank you. Any specific questions if I have missed something, or if someone would like to pitch in?
Thank you, Purnima, for taking us comprehensively through the guidelines set by Marseille Society and what we as a chapter can look forward to and come together to think of. I now invite Dr. Prabhat Chandra and Dr. Geeta to come forward and share their thoughts about the launch of the South Asian chapter for Marseille Society, and to have a brief discussion about it.
Thanks,
Sorry.
Yeah, thanks. Yeah, I think, you know, first of all, I must congratulate the Green Initiative, especially Dr. Shlesha, for taking the lead to organize this meeting. I mean, as you saw, the richness of the discussion, the enthusiasm was so, I mean, it's so heartening to see this. Maybe we should have started much earlier, you know, started these dialogues, but many interesting topics, you know, and priorities have come up from each region. So I think the first thing that we will probably do is, because we've recorded this whole thing, transcribe what has happened in this, and make sure that we have that as our background document, so to say, like what things were raised by different countries. Also, maybe we need to have something like I wouldn't call it a mission statement, but at least some kind of an idea about where we are going. And those of you who want to become members of the International Society, usually it's a January to January membership. So we are already in May, but because it's a fairly reasonable, $20 US, so it's about, like in Indian rupees, it's 2,000. I know Sri Lankans right now may not be the best time to do it. We're sorry about what's happening there. But I think for those of you who can manage to become a member, so that you get a sense of the listserv and what kind of discussions happen, and what are the subgroups over there. That is something that to start we can do. And by January next year, we will have more clarity about how we want to handle the membership fees, etc. And also by then hopefully we will have our team ready. So I think the idea also probably, my sense is that the Green Oak Initiative will be the people who will register the society in India, because it might be easier that way if people don't have any objection to that. We also are very, very clear that we do want participation from every country in the region, and adequate participation. So I think that part is very important, because as we saw, there's so much of activity and richness in each country, and maybe even the leadership can sort of rotate between each country, so that that's in the true spirit of collaboration. Also, there's been just now, Dr. Siham Sikandar has suggested, is there some way in which we can share news activities? So maybe, like a newsletter format, which is more sort of web-based kind of a newsletter, where we can start with talking about research initiatives, service initiatives, training initiatives. Now with the world opening up the way it is, online, there are many certificate courses and other courses which are going on around around this region. So it is something that we can start. I also I realize that there are so many areas that we need to be talking about. So maybe at least maybe at least every 2 months to have like an academic program with with a lot of variety. So maybe have a 2-hour program every couple of months, where we learn new things or share ideas or do research presentations or talk about whatever else we're doing. So I think that might be something as a run up to the final thing in January. So that's what I'm thinking. So to just summarize, to at least start a newsletter, to get our sort of constitution ready, to elect a EC, and to also start this newsletter, and have a program every 2 months. So it's May now, so probably till January, we can easily have at least 3 programs once in 2 months. And we will look at all the things that have been raised as priorities, and maybe, start and use different methods and formats and learning styles, and etc. so that it's interesting and enriching to all of us. So those are my thoughts.
Thank you, Dr. Prabha, for sharing these wonderful thoughts. I'm sure all of us are excited to take them forward. I now invite Dr. Geeta to share her thoughts about the chapter.
Ketaki, there's just one thing I want to add here, which is something which got missed in all our discussion, and I thought you might raise it. So one of the issues that is very important in maternal mental health is forensic maternal mental health. And I think we probably need to pay attention to that. As you will see in the Marseille listserv as well, there are many situations where mothers are, convicted of infant harm, etc. And it has been, the International Marseille Society has been a great way to advocate for these women. We've done that in the past for America. We are currently struggling with a case in India, and Ketaki is very actively involved in that. So I think that is another initiative which we need to sort of kind of think of as well.
Thank you, Prabha, for adding these points. I now invite Dr. Geeta to share her views and thoughts about the chapter.
Yeah, I think pretty much, I think Dr. Prabha has covered everything in terms of, what's going to happen in the next. But I also thought that I think since it's going to be the, first time we're doing something, probably having regular, some sort of a meetings, which can be like a lecture or a case conference or something that, highlighting and I also want the focus not predominantly driven by mental health professionals, but various other professionals as well, to take initiatives to, have some sort of an academic program. But I think to begin with, maybe we can have the first newsletter discussing, at least in terms of, by then hopefully we will have some idea in terms of, the membership and other things, at least discussing some of these important things. But otherwise, I think we are looking forward.
Thank you, Dr. Geeta. I'm sure all of us are looking forward equally. There are a couple of questions on the chat box. Do we want to take them? So there is this question by Aisha. Aisha is saying that Aisha Nurullah is also congratulating the idea of a newsletter and forensic mental health as well. Right. I hope, Dr. Shiham, you got the link for the for becoming a member. Yes.
Yes. Thank you very much. Got it.
So just in response to that, I think, I'm glad that we are sort of bringing in forensic mental health, and that can certainly be something that we can focus on in our South Asian region, because it's very, very nascent and new. And what I'm thinking of, Dr. Prabha, in addition to what you're saying is, like you said in your initial talk, that we might have to look at a lot of transformation. Education, of course, advocacy, action, but transformation. And while we're looking at other regional chapters, we may also have to come up our own innovative ways of, working through our region. Our region has its own special challenges. So as a next step, I think it would be great if we can, have people, if you can nominate yourselves and email us about your interest in being part of the South Asian Marseille operational system, just the executive system at least, because in the next 6 months, we are going to formalize it. And we are, I'm very excited with just your enthusiasm and the interest that was there today, and just blown away by all the work that is being done despite the lack of resources. So it would be really nice for us to come together. And I think even once every 2 months, if we, I think taking forward from what Dr. Prabha's idea, it would be great if we could have each country sort of hosting it, so we can hear more about activities from the different regions in the coming months. And that can be a way of sort of thinking, how does the region come together? So if we can also, if I can encourage all the panelists to share these details of the Marseille International Society with their mental health professionals, anyone who's working in the perinatal field, consumers in their country, so that we can, invite dialogue from them as well. And if you think there's anyone else who's interested in becoming a part of, the South Asian Marseille region, then please ask them to get in touch with us. And we can hope to form have a meeting within a month, so that we can start the process. Yeah. There's a question. Yes, Sonali, actually, I should have mentioned this. Anyone from any region can become a member of any region. So, I know that especially Australasian, UK, there are people who are just members of that region, but they might be living somewhere else because they travel. And definitely for South Asians living outside of the South Asian region. And I know there are many of you. In fact, we feel like you can be very actively involved and contribute greatly in helping with the collaboration. So definitely it's a possibility to be involved. Of course, we'll just find out from from an operational point of view as to which membership you'll be eligible to, but I think it should be the same as South Asian regional member. So we would, everyone who has an interest in South Asian mental health, perinatal mental health, can become a member. That's how we would see it. I wonder if anyone
a request for an email. There's a request for an email address where people can communicate about Marseille. So maybe if Purnima can create a South Asian Marseille sort of email address, so people can communicate directly to the Green Oak South Asian Marseille.
Yeah, we'll do that. We'll send an email, and for now, anyway, whatever emails you've received, the link from all the participants, we have your email address, so we'll send out a notice of upcoming activities. Also, you can get in touch with any one of us if you haven't heard anything and want to know more. We'll notify through the usual channels of your organizations, your networks of, say, psychologists, social workers, psychiatrists, obstetricians. But just get in touch with any one of us if you felt like you haven't heard and you'd like to hear back. We'll form a specific email as well for the Marseille, South Asian Marseille chapter. I don't know if does anyone else from the panel have anything to add? Any ideas that you have? Any ideas for names? Of course, you can think about this. Dr. Siham, do you want to add anything?
Nothing at the moment. I think we've covered substantial ground, and now there are quite a substantial things to follow up on and see how this shapes up. So thank you very much for kickstarting this very important chapter and very important initiative.
And I think, thank you, Dr. Siham, for that. And like Purnima mentioned, for all those interested in the South Asian region, if you are attending the Marseille conference in September this year in London, we can definitely meet there as well. So you need not be in the South Asian region. So that would be a great place for us to catch up. A lot of the regional groups do that. They have a breakfast meeting or a lunch meeting. And Dr. Prabha, I think we can definitely try and do that. One of our meetings can be definitely there in person. And hopefully we can also do more in-person meetings. Right now it feels like such a weird thing to not be sure of, but we'll try and do that as well at some point. Okay, so if there's nothing else, I have a special message from Dr. Louise Howard. Shall I move on to that? As next steps, we will be writing to everyone, and we'd love some, interest from all the countries, neighboring countries. And we will, yes, Dr. Siham, we'll also form a process to how to take these things forward. Dr. Siham is asking what will be the process or mechanism to share any findings. And I think it will be great to have the South Asian chapter as a launch pad as well, where all this can be shared and that gets shared with the International Marseille Society as well. So definitely all activities that is happening in the South Asian region, if we can start highlighting them through the newsletter, that would be a great starting point.
Sure, the country which is kind of missing is Afghanistan, and I was wondering if people have contacts there. And Bhutan, I think, comes under the South Asian region. So I think maybe Afghanistan, definitely. I know there's work going on in perinatal mental health there, and including gender-based violence. So maybe we need to actively get people from that region. And so if any of you know people who would like to be interested, please invite.
Yes, actually Bhutan, Afghanistan and Maldives. I know Maldives has some mental health initiatives. They've invited people over from India. I don't know about the perinatal mental health, but definitely if anyone is from any of these countries or can connect us, then that would be great.
Can I say something regarding Maldives?
Yes, yes, please.
Okay, we have done the contextualization of MH gap intervention guide for Maldives from Bangladesh.
Excellent.
And hope from 20th May to 27th May, a team from Bangladeshi psychiatrists will visit there and provide a master trainer training on MH gap. And that also includes the women's mental health, especially the two parts is there. One is the postpartum depression, another is the depression in women. So participants are the doctors, nurses, and some mental health experts from the Maldives, and the trainers are from Bangladesh, 20th May to 27th May. And I also joined the Bangladesh team also. Thank you.
Thank you. That's actually very useful. And I think that is an interesting sort of thing to keep note. The mental health gap program that you're talking about, Dr. Halal, actually it's a very useful program for us to link up with, because that's even though it's not limited to the South Asian region, it can be something that we can sort of collaborate with, and because there is a lot of work that is done in the South Asian region by the WHO mental health gap program. So definitely that would be very useful. Someone shared. Excellent. Thank you so much for sharing that. We'll make a note of that. Alexis is saying we have colleagues in Afghanistan, but it's pretty dangerous at the moment. So our team has had to suspend work indefinitely. And you can't send funds easily because of it being tracked. Of course, you know, as we listen to this, we also can't help but think that, you know, it means that their mental health needs are also quite high and neglected, right? Not having access. So I'm hoping we can keep an eye on the space and, you know, continue to collaborate. So, you know, if anyone is doing any work, let us know, and maybe we can form part of the chapter as well. Okay, so I will just share a very important message that Dr. Louise Howard, who's the current president of the International Marseille Society. Let me just.
Hello, good morning. My name is Louise Howard, and I am president of the International Marseille Society. And it is a real pleasure to be talking to you, Prabha, and your colleagues, so far away from here, but well connected as well. So I hope to make you feel very much part of the Marseille family. This is the only international society for perinatal mental health, and it really is the global home of both perinatal and infant.
I think you just keep pressing on the slides, Ashleisha.
Okay.
We started at an international conference in the UK, and a number of mostly male professors at the time decided to start this society as there seemed to be a real gap in understanding of mental health problems in pregnancy and after birth. The society was named after a French psychiatrist who wrote the first treatise entirely devoted to mental illness in the perinatal period, which we now abbreviate pregnancy and the year after birth too. And his treatise was published in 1838. Our mission is the well-being of mothers and their families during that time. And we're very much a multidisciplinary society. We have advocates, women themselves with lived experience, researchers, and of course, practitioners of all types, working towards well-being in women, partners, significant others, infants, and their families throughout pregnancy. And we have extended the perinatal period for our society to be the first 2 years after childbirth.
We have a broad range of research activities, of dissemination activities around basic science, around healthcare, and also development of best practice in terms of healthcare system. We've grown globally. We have 10 official regional groups around the world, and we are very much looking forward to welcoming your. So what do we do? Well, we're very much a place where we want to share experiences and knowledge. So we have a very active listserv, which is it's used for asking questions, clinical questions, maybe asking about services, if a patient of yours is moving to another part of the world, and just general networking. It also has we also have a lot of links to resources for researchers, clinicians, and the public. We have annual and biennial conferences. In my country, the UKIMS is an annual meeting. That's the UK and Ireland Marseille Society. And as you may know, the International Biennial Conference this year is in London, the 19th and 21st of September, and the virtual programme for those that can't get to us face-to-face the following 2 days after that. We're also involved in a scientific journal, the Archives of Women's Mental Health, which is going from strength to strength. And we sometimes write position papers and other types of papers to support anything in particular that's happening at that time. We have more emerging regional groups, I'm delighted to say. We've also developed something relatively recently, which has really been so helpful, I think, and this is special interest groups, and there are special interest groups on fathers, there's one on perinatal loss, forensics, pregnancy denial, and prevention. So these are doing work, internationally and looking at how to take these areas forward. We have an international Marseille mentorship program, and this is again very international, so super interesting. My mentee a while ago was somebody developing services in a part of Australia. So we were learning a lot from each other about the different healthcare systems and how to make them work for her in her particular part of the world. We try to have affordable membership rates as much as we can to keep the society going, and we particularly have low rates for people from low to middle income countries. And similarly, we have reduced rates for both the face-to-face and the international virtual conference program in September this year. We do go global, we really do. Our conferences have been held all over the world. As you might know, in 2018, Society held its first conference in Bengaluru in India, which we were very excited about. And we were particularly excited because one of our local groups, the Institute of Health Visitors, received a prize there. So when we go international, you never know who might, in another part of the world, find that a particularly exciting conference for a prize. Or two. We've had some pilot workshops in webinar type format, which have been very well received, and we hope to do more workshops in the coming years. We've also developed a lot of resources around COVID-19, and hopefully that will be helpful even outside of the pandemic. So these resources have been collected for both clinicians, academics, and also resources for patients. So do have a look at those. If you're interested in those. Save the date, try to come if you possibly can to our conference, and if not, you're all welcome to come to the virtual element on the Thursday and Friday of that week, and I do hope to meet you all very soon.
So that was Dr. Louise Howard, and she did reiterate some of the things we said, and I'm so glad that you got a chance to hear from her. I don't know if you have any other questions or comments from anyone else. So, once again, I would like to thank everyone. Thank you, Dr. Prabha Chandra, for leading the way for us in the field of perinatal mental health in the South Asian region. Thank you very much to Dr. Geeta and all the panelists for just dedicating your Sunday morning to us and sharing your really interesting work and the challenges that you face and are still at work. I think, Dr. Halal, you look like you're at work while you're attending to us. So thank you very much for that.
Yes, Sunday is our open day. Sunday is our open day. Our holiday is the Friday. So today is my office day. Thank you.
Okay. Well, a special thanks to you then for joining us despite your busy day. And thank you to all others who have been here to help me, Dr. Purnima, Ketki, and Pavitra, who's also our co-founder at the park. And we will be letting you know of any upcoming training that is going on. The training that we talked about for the obstetricians is up and running, and we'll be launching the next date soon. It's also very well received by the obstetricians, and we hope that we can have similar models of training for other specialties. But also we are hoping that the training for obstetricians can be rolled out to the other countries in the region as well, the other South Asian countries. So watch this space for our next information, and please, let us know if you want to get actively involved in the South Asian Marseille chapter. Thank you, everyone.
Thank you. Thanks to everyone.
Thank you very much. Have a great rest of the day.
Thank you so much.
Pleasant week.
Thank you, Dr.
Bye, everyone.